Assalamu alaikum, good afternoon. My topic for today is about the consensus recommendations for blood culture use in critically ill children using a modified Delphi method. This is from the Pediatric Care Medicine, September 2021. So for the introduction, blood culture practices in critically ill children vary widely, and overuse of cultures can lead to false positive results, unnecessary antibiotics, and patient harm. Diagnostic stewardship efforts can safely reduce blood culture overuse, but no standards or guidelines currently exist to guide clinicians in specific scenarios. So to meet this need, a multi-center collaborative called Bright Star used a modified Delphi method to develop the first ever consensus recommendations for reducing blood culture overuse in PICU. The objective of this study is to create a consensus recommendations focusing on when to safely avoid blood cultures in PICU patients. So for the methods, a brief description regarding the Bright Star Collaborative. Bright Star means Blood Culture Improvement Guidelines and Diagnostic Stewardship for Antibiotic Reduction in Critically Ill Children. It is a quality improvement collaborative of 14 PICUs across the US that started in 2018. This is led by a multidisciplinary coordinating team with expertise in pediatric infectious disease, pediatric critical care, patient safety and quality, and human resource engineering. Their goals are to improve the use of blood cultures in critically ill children by standardizing practices and safely reducing unnecessary cultures and their consequences, such as unnecessary antibiotics. So for the methods, they selected a modified Delphi method. Delphi method is a process used to arrive at a group opinion or decision by surveying a panel of experts. And here they used a 2-round modified Delphi method with electronic email adaptation. So they sent the recommendations to the participants via email, and they rated this one in the round 1. And in the second round, the participants they had an in-person meeting regarding these recommendations. For the expert panel, the coordinating team, they bring about a multidisciplinary, multi-institutional physician expert panel. They invited 34 experts in pediatric ICU, in pediatric infectious disease, also from oncology, nephrology, and microbiology. And some of the national societies were also represented, like the Pediatric Acute Lung Injury and Sepsis Investigator Network, the PALISI, and also the Saudi Critical Care Society of Critical Care, and also the Pediatric Infectious Disease Society. For the literature review and development of recommendations, they conducted a scoping review on the blood culture use in pediatric patients, and they compiled a summary of the existing pertinent literature. And based on this literature review, they developed 27 recommendations, and this was circulated to the participants. So the intended use of these recommendations, consensus recommendations, are based on the subject matter experts' synthesis of evidence, current practices, practical considerations, and consideration of potential harm where applicable. These recommendations do not encompass all clinical situations, are not meant to be a substitute for individual clinical judgment by qualified professionals. And every recommendation is based on the absence of any signs or symptoms concerning for sepsis, as determined by the judgment of the clinicians caring for the patient and the current national guidelines. So for the results, so as I mentioned, they had 27 proposed recommendations, and in round 1, 8 out of the 27, 18 met the criteria for consensus, and 9 did not meet the criteria for consensus. And in round 2, the 18 that was already included, it was condensed into 12. And out of the 9 that was not included in the round 1, 5 were included. And a new recommendation was also included in the round 2. So a total of 19 recommendations. So this is just a sample of their algorithm. I will be discussing the recommendation one by one this slide is not clear, but in this slide, they just made like algorithm what to do prior to blood culture decision and what not to do, and in asymptomatic patients when to avoid blood cultures. Also in those patients with fever without signs of sepsis, if the fever is new, when to do or what not to do in immunocompromised and immunocompetent patient with or without the central venous catheter, and also with the same with the persistent fever. So for the consensus recommendations and general clinical practices for blood cultures in critically ill, number one, clinicians should review a patient's clinical data such as vital signs, existing laboratory and imaging data, urine output, recent cultures, current antimicrobial therapy prior to making the decision to order or not to order a blood culture. Clinicians should perform a physical examination prior to making the decision to order or not to order a blood culture. And third is clinicians should discuss a patient's clinical status with the bedside nurse to inform the decision to order or not to order a blood culture. These first three recommendations, it may look obvious, but they had data that they found that the pre-culture data review and physical exams are not typically done by the PICU providers before ordering blood cultures. So the panel felt it was wise to specifically call the attention to these recommendations. Number four, avoid surveillance culture like daily screening blood cultures in patients who are on ECMO, who are on CRRT, and also on those patients who are immunocompromised with or without central venous catheter. Regarding the ECMO, the Extracorporeal Life Support Organization, they recommend against sending daily blood cultures. And this is because a study showed that there is a lack of data demonstrating the benefit from these practices. And regarding the CRRT, also studies suggest no role for routine surveillance blood cultures, and that in pediatric patients who are on CRRT and who develop bacteremia, usually these patients will demonstrate clinical signs of infection. Number five, blood cultures in asymptomatic patients who experience inadvertent central venous catheter disconnection. And number six, avoid blood culture in asymptomatic patients who have a broken or cracked central venous catheter. For this, accidental central venous catheter disconnections or breaks, it will increase the risk of catheter contamination or bloodstream infection. But the sensitivity and specificity of a blood culture to detect a catheter contamination and predict infection in asymptomatic patient is unknown and most likely poor. So they reach a consensus that a blood culture in such scenario should only be targeted to those. Number seven, avoid drawing cultures from peripheral IVs. Multiple studies demonstrate that there is a high contamination rates and false positive results for blood cultures samples taken from existing peripheral IVs. Number eight, avoid a blood culture in patients with new fever within 24 hours after surgery with no signs of sepsis, with or without a central venous catheter in place. So the patients who are post-op, immediately post-op, inflammation related to the surgical procedure is the most likely cause of fever. So having an infection within 24 hours, it will be infection would be is considered not to be the cause of the fever. So in such cases, they don't recommend to do blood cultures within 24 hours unless patient is having signs of sepsis. For number nine, avoid blood culture in patients with viral syndrome such as bronchiolitis, new fever, no signs of sepsis, and without central venous catheter in place. So in patients who are having viral infections, the likelihood of bacteremia being the cause of the fever is low, especially in patients without a central venous catheter. So, and also they had studies like for the RSV that documented very low prevalence of bacteremia. Number 10, avoid blood cultures in patients with viral syndrome such as bronchiolitis, persistent fever within the expected time course for viral infection, no signs of sepsis, and without central venous catheter. Um, Also, this recommendation, it aims to reduce unwanted blood cultures in the setting of uncomplicated febrile viral syndrome. But here they included within the expected time course for viral infection. This is for the providers, reminding the providers that if the fever is, what is this, is no longer, it does not explain a viral syndrome. So this patient should be worked up for the fever. But they said it's up to the clinician regarding the opinion how long the expected time course for the viral infection. It's up to the clinician. Number 11, blood cultures in patients with a localized bacterial source of infection like UTI or focal pneumonia, persistent and expected fever, no signs of sepsis, at least one negative blood culture obtained within the start of fever, without a central venous catheter. So here, patients with localized bacterial infection, usually they remain having fever even after starting appropriate antibiotic therapy. So they said that the likelihood of having a secondary bacteremia on antibiotic therapy is low, especially in those patients with no other risk factors such as having a central line. Oh, sorry. Number 12, avoid blood culture in patients with new fever, no signs of sepsis, with symptoms of withdrawal while undergoing a wean of a sedative opioid infusion and without a central venous catheter in place. So as here in PICU, we always have patients who are on sedations, and usually when it is prolonged and once we wean these sedations, we sometimes expect patients to have the withdrawal syndromes, and one of these is fever. So here they mentioned that if the patient responds with rescue medications for the expected withdrawal, or like here, if we give the bolus of benzo or opioids, then the symptoms like patients having fever, they differ this. So that means that the fever is secondary to withdrawal. So for this kind of patients, they don't recommend doing the blood cultures. Number 13, avoid repeat blood cultures in patients with symptomatic viral infections such as bronchiolitis, persistent fever within the expected time course for this viral infection, no signs of sepsis, and who has already had at least one negative culture obtained since the start of fever with central venous catheter in place. Also here, it is the same as previously stated that patients who are having the viral infection, they usually have persistent fever with its expected time course. But here they said that if the fever persists beyond the expected duration of the viral illness, then the fever should be investigated and blood culture should be taken. Number 14, avoid blood cultures in patients with a documented localized bacterial infection, persistent and expected fever, no signs of sepsis, and who has had blood culture that is negative to date, obtained within the last 48 hours, and with with a central venous catheter. So patients with localized bacterial infections, they are most of the time febrile even after starting the antibiotic. So for these children, they are expected to show improvement or show response, including the improvement in the fever within the 48 to 72 hours after initiation of antibiotics. Although the Pediatric Infectious Disease Society, they had a guideline for community-acquired pneumonia, and they do recommend obtaining a blood cultures in those who has progressive symptoms or clinical deterioration after initiation of antibiotics. Number 15, for persistent fever in immunocompetent patients with central venous catheter, suspected non-infectious etiology of fever. For this, they mentioned about heart failure or those who are having withdrawal symptoms or with autonomic instability. And no documented source of infection without signs of sepsis and with initial set of negative blood culture, avoid additional blood cultures. So for these patients, they said that the value of repeat cultures for the purpose of identifying bacteremia is expected to be low. But they do agree that there should be at least one set of negative blood cultures for such a scenario. Number 16, avoid blood culture in patients with new fever, no signs of sepsis, and with the symptoms of withdrawal while undergoing weaning of the sedations or opioids with a central venous catheter in place who defervises in response to treatment of withdrawal. This is the same as the previous one, but this time with a central venous catheter in place. So the same, they also mentioned that if patient responds to the rescue therapy, then we can avoid the blood culture. But in those patients who are with central venous catheter and who are persistently febrile, in spite of giving the treatment for the withdrawal symptoms, then this kind of patient should receive blood cultures. Number 17, for persistent fever, in patients with central venous catheter and without signs of sepsis, if a recent blood culture from the catheter is no growth to date, and then the subsequent cultures, if indicated, do not need to be drawn from the catheter. For these recommendations for this, their explanation is that the yield from the blood cultures will drop dramatically upon subsequent draws in patients on antibiotics. And if additional cultures are indicated or desired by the clinicians, they advise to do the peripheral venopunctures rather than from the central line. And for these last two recommendations, this is the consensus recommendations on blood culture practices in symptomatic immunocompromised critically ill patients with or without central venous catheter. So number 18, this is after repeated negative to date blood cultures. Avoid additional blood cultures in immunocompromised patients with persistent fever, but without signs of sepsis or infection in whom you do not plan to change or you don't plan to broaden the current antimicrobial regimen. So we all know that blood cultures, it's part of the clinical care for immunocompromised patients with fever. But the frequency with which the cultures are repeated it should be also be considered, like, for example, patients with febrile neutropenia and in the absence of sepsis or a new fever. When blood cultures are taken beyond 48 hours, it will they said that it will show limited yield. And there are also studies that demonstrate that when blood cultures are obtained within every 24 hours in the setting of ongoing fever, majority of the blood cultures utilizations occurs during this time are of lowest diagnostic yield. And for persistent fever in immunocompromised patients without signs of sepsis, if initial set of blood cultures from all lumens of the central venous catheter were negative, avoid repeatedly culturing more than one lumen of that central venous catheter. They mentioned that in general, blood culture should be preferentially be obtained peripherally, as there are strong data that suggest that the risk of contamination is greater with central venous catheter blood cultures. And that's it for the 19 recommendations. And during their round two discussion, they suggested they had a suggested implementation strategies for consensus recommendation from the Delphi panel. And number one, this is secure buy-in from leaders and key stakeholders. by providing literature supporting the recommended practices. Second, assess local practices and engage stakeholders to adapt the recommendations for local guidelines. Also to provide education like orientation, presentations, reminders to all PICU clinicians, and prepare materials like scripts to explain recommended practices like the doing peripheral cultures to patients and to families. And also apply a phased implementation strategy, like starting with a subset of PICU patients and growing and or spreading to other PICU populations. And the use of electronic medical record and other tools or technologies like text messages to integrate recommended practices into daily workflow, and to address other system challenges like unit layout or spatial distance between physician workroom and patient's room. And lastly, collect data on compliance with and impacts of recommended practices, and provide feedback to leaders and key stakeholders continuously. For the limitations of the study, the majority of the expert panelists that participated are also involved in the Bright Star Collaborative to improve the blood culture stewardship. This will likely impact their evaluation of the proposed recommendations. The panel was not balanced with respect to race and or gender, and generalizability of these recommendations is limited owing to the nature of the modified Delphi work and the sample size of the participating experts. And use of these recommendations requires clinicians' expertise in managing critically ill children and ability to frequently reevaluate patients in highly monitored setting of PICU. These recommendations should not be used in the absence of either of these important elements of PICU care. And for conclusion, a multidisciplinary expert group created 19 recommendations to reduce unnecessary blood cultures in critically ill children while maintaining an appropriately high index of suspicion for patients with potential infection who need blood cultures. And this recommendation represent the first guidance of their kind in pediatric critical care and may allow standardization of a highly viable clinical practice and reduction of unintended harm from unnecessary testing and treatment. Evidence to direct many recommendations remains limited in this patient's population, and their inability to achieve a consensus in some areas underscores that further work is needed to better inform clinical use of diagnostic testing in the PICU setting. Thank you. Any questions?